This is assessment and plan for V551, ocular motility and refraction. Assessment and plan. The assessment and plan is a short synopsis that encapsulates why someone was diagnosed with a disease or disorder and what was done about it. It is the communication step where you inform the following people. 1, your future self, for future exams when you see that patient again. For future caregivers, in the case of IU's clinics and future students who will be seeing patients in our clinic. And it also informs the insurance carrier why you did certain procedures and why you billed certain things. It should be short, easily readable synopsis of what happened at that patient visit. It is the first thing you should read before seeing a patient if it is available. So on a return to clinic, the first thing you should look at is the assessment plan, which will educate you on what you should do with the patient and what's going on with that patient. Essentially, it's a summary of what's happened in the past. To make an assessment plan, we first need a diagnosis. So anything with a diagnosis has what's called a diagnostic code or an ICD code. Right now I'm showing you the ICD-10 codes, and they change every 2 to 4 years, so don't be worried about memorizing these numbers by any means. Electronic medical records will pull those up for you. But regardless of that, these codes are tied for insurance companies, and that's what we use to signal what diagnosis we have within a patient. In this example, this is the refractive codes only. There are literally thousands of codes for ocular disease. The assessment is where we comment on the findings from the examination that lead to the diagnosis, how severe it is, whether it is progressing or a stable problem. The assessment may include any or all of the following and other things as well. 1, the type of refractive error. 2, any non-traditional testing done to determine the RX, in this case cycloplegia or prescribed off-retinoscopy. These are things that might modify our confidence in our prescription. Number 3, why did the patient not achieve 20/20 if they didn't achieve perfect vision? Number 4, significant systemic or ocular issues that may modify the RX over the short term. So things like diabetes or cataracts. If somebody's blood sugar is way out of control, then their vision might fluctuate and their prescription will fluctuate. Number 5, any pertinent findings that might have made you come to this decision. The plan is the part where we describe what we are doing about the problem. The plan may include any or all of the following. RX advised and prescribed. This includes the lens power, the style, single vision, progressives, etc. When the glasses should be worn, full-time, or reading only, as an example. Number 2, significant issues with ocular or systemic health for the eye and the vision. Number 3, patient education on expectations from the new glasses. Some patients might have a large adaptation time, so we might want to tell them that, and then we will document that we did that. A recommended return to date clinic date is always required in any assessment plan, whether you're talking about refractive error or disease. Today, we're only talking about assessment plans primarily for refractive care, but this applies as well to retinal disease. Any specialty lenses advised, including polycarbonate for safety or sports, sunglasses, or anything like that, specialty lens glasses for piano or music, these would also be advised in this section. Let's look at 2 assessment plans, one for a refractive diagnosis and one for a disease diagnosis. Here we have myopia as the refractive and primary open-angle glaucoma as the disease diagnosis. The assessment can be very different. Refractive error assessments are typically much simpler compared to disease because we have less to document as far as pertinent positives or negatives, pertinent positives being tests that came back positive to indicate that disease, and pertinent negatives being tests that came back negative that says it's not that disease. In our assessment for refractive care, the assessment is a 15-year-old presents with myopia based upon subjective refraction. Conversely, with our glaucoma, our assessment is a 65-year-old patient with glaucoma was diagnosed with glaucoma due to what pertinent positives and negatives? Well, they could have large optic nerves, and so that's why they were diagnosed with glaucoma. They also had a family history of glaucoma, though their visual fields were normal OD&OS, which was a pertinent negative that make us think that he might not have glaucoma. IOPs were 25 and 26 above normal, so again, that indicates glaucoma. But when you get to the plan, they're actually very remarkably similar, even though the complexity of the assessment was very different. The plan, spectral RX given, we recommended polycarbonate for safety as a patient is a minor, and they should always be protected if they're under the age of 18, or if they're monocular or in some other conditions. Return to clinic in 1 year for a complete examination. Conversely, in the diseased plan, we RX Travatan, a medication to lower the pressures of the eye. We also gave a return to clinic, in this case 3 months, for a dilated fundus examination with OCT and IOP check. Patient educated on glaucoma. If you look at both of these, the plans, we RX something, one a spectacle and one a medication. We recommended a return to clinic, and we also recommended what additional testing should be done at that visit. In the refractive case, we were just having come back in a year for a complete examination for full testing. For the glaucoma case, we're having them come back for additional testing, specifically OCT and IOP, but we're also asking for a dilated fundus exam. In both cases, we told them when to come back and what we're going to do in the future. This is the part where we tell ourselves what we're going to do with next visit. Now, here's an example of an assessment and plan from our clinic's electronic medical record system. There's really 4 kind of general areas that are critical to fill out. There's the diagnosis area, which we can see our list of our diagnoses by date of visit. Or then we have our assessment in the box right beside it. And finally, we have our plan, which exactly we went over just a few minutes ago. And then we also have our return to clinic area, which this is purely for front desk staff to call back patients. Either way, though, we typically put the return to clinic both in the plan as well as we fill it out electronically in the return to clinic dates. Now, here's a more realistic list of an assessment plan for somebody over the age of 65. You'll notice that there's a list of 6 items here. There's actually says 7, I know, but there's actually, if you count through the numbers, there's only 6 diagnoses because the student misnumbered things. But you'll notice we have a list and an order of those diagnoses that seem at front face very random. Each one of those, 1 through 7, has an assessment and a plan for each diagnosis. Now, sometimes those assessment plans are identical. So for the myopia and astigmatism and presbyopia, the assessment plan might be identical for all 3 of them because we're treating all with refraction. We diagnosed them with refraction, and we're treating them with glasses. If you notice, though, in this specific case, in our myopia example, we did have an assessment plan. We had comments on it interacting with our cataracts diagnosis, which was the number 1 diagnosis because of the person's chief complaint, which we'll get into in a minute. But we comment on the cataracts because it modifies the person's vision, and they don't see 20/20 because of the cataracts. And also, our new RX probably will not improve the vision very much based upon the cataracts. If you notice also in the return to clinic, we always fill out the type of reason for the exam and what we're going to do, just like we did in the plan, so that we know it's a complete exam with dilation. Now let's think about that order we just saw up here. How did we come to that order? The most critical one is the chief diagnostic complaint that we're going to decide upon. That's number 1. That's what the insurance companies look at. That's what they care about the most. Primarily, the number 1 choice for our diagnostic codes in our list is going to be based upon the chief complaint upon entering. What diagnosis most contributed to that chief complaint? And that's the way to think about it. Well, in this case, we have two patients. One comes in with a chief complaint of, my vision is blurry at distance. The other is, I would like to have my glaucoma checked. Well, upon examination, we reveal that both of them have glaucoma and both have myopia. What order do we put those 2 diagnoses in for each patient? Well, in this case, the chief diagnosis for the patient with blurry vision is myopia because myopia causes distance blur, glaucoma does not. So myopia becomes our first diagnosis. Conversely, if I want to be checked for glaucoma, glaucoma is my chief complaint. So it becomes number 1. And so the chief complaint generally guides what your number 1 and number 2 diagnosis will be. The only exception to that is the insurance types that the patient has. If a patient has vision insurance only or vision and medical, you'll have to decide which one of these based upon the insurance that is being billed. Vision insurance only covers refractive diagnoses. Health insurance or medical insurance only covers disease diagnoses. So if we're going to bill their patients medical, we need to have glaucoma first. If we're going to diagnose their refractive care, we need to diagnose their myopia first. That's the only modifying factor that might change your order of diagnoses, depending on the chief complaint and what they had in the assessment plan. Now, our assessment plan from previous years can also modify this. If we ask them to come back to have their glaucoma checked, that might become number one because we were the ones that caused them to come back. Let's look at some more examples. In this case, we have a chief complaint of distance blur in both cases. The person on the left of your screen has 2 diopters of myopia and a half diopter of astigmatism. The person on the right side of your screen has a half diopter of myopia and 2 diopters of astigmatism. So based upon the one that affects the chief complaint the most is the order of the diagnosis. In our example where the myopia was higher, the chief complaint of number 1 diagnosis is myopia because the myopia was the bigger cause of the distance blur. In the second example, where we have 2 diopters of astigmatism in the right eye, the astigmatism could become our chief diagnosis because it's the bigger contributor to the chief complaint. Let's look at a few more examples. Here we have of assessment plans. We have 2 myopes here. They're both 15-year-olds based upon subjective refraction, so there's no difference whatsoever in our diagnosis or assessment. Here's 2 different ways. Both are totally acceptable to write out, where we write out that the spectral RX was given in the first person, and in the other person, we actually write out specifically the refractive error that we gave the person, what we prescribed. Generally with EMRs, we don't write it out anymore in the plan, but oftentimes doctors still will do that. That was an old practice before EMRs, so you'll still find some clinics that you go to where that is done, and it is totally acceptable to still do that. You'll also notice that we recommended polycarbonate because this patient was again under the age of 18, so all minors should be recommended polycarbonate for safety reasons. Now let's look at a presbyope. In this case, again, the diagnosis and the assessment are identical. There's no difference between the 2 of them. They both presented with presbyopia based upon subjective refraction and near testing. But we've now varied the plan. And what made us decide to vary the plan? And that was the decision of the doctor of how to prescribe the glasses. So we've had a discussion with the patient of what they wanted to use the glasses for and where they had problems at. And between the doctor and the patient, we've come up with a plan for their glasses that was different, even though everything else was identical. In the patient on the left, we're giving an RX for full-time wear, and we recommended progressives. But because this is the patient's first time wearing progressives, we need to educate them on first-time wearing of PALs and adaptation times. We ask them to return to clinic in 1 year for a complete exam with DFE. In our second patient, we've decided to give them a near RX only. This patient decided he only wanted to wear reading glasses, so we gave a RX given for near only. There's not as much complexity to that, and so the patient doesn't necessarily have adaptation times typically, so we didn't need to worry about that in the plan. But we still had to have the return to clinic in 1 year for complete examination. Thank you.